Alright, hi guys. So let's start the recall of FMG, and right now we are going to discuss June 2022. Now this recall that we are going to discuss is one of the most authentic recall, and I would say that we have put a lot of time and effort from collecting the data from the students usually, and it has taken a lot of time, and definitely you guys are going to enjoy this FMG June 2022 recall. So let us see the very first question that was asked in this recall. A patient with glaucoma was also suffering from bronchial asthma. Now, in this June 2022, there were three questions that were related with the bronchial asthma. One is glaucoma with the bronchial asthma, and his examiner is asking which of the following drugs should be avoided. Now, in the bronchial asthma patient, what we usually discuss that what should be avoided is always and always going to be non-selective beta blocker, because non-selective beta blocker, they will be blocking beta 1, beta 2, and on the lungs we are having beta 2, right? This non-selective beta blocker, they are going to block beta 1. When they block beta 1, there will be decrease in the heart rate. But when they block beta 2 as well, what will happen? Lungs, bronchial smooth muscle of the lungs, we are having beta 2, and because of that, beta 2 normally causes bronchodilation, and because of the blockade of the beta 2, now there will be apparent bronchoconstriction. So any bronchoconstricting effect can cause the problem. Therefore, a drug like timolol, as I tell you, that in any general patient, especially in a country like ours, we prefer timolol, right? Timolol is a non-selective beta blocker. It is a drug that can precipitate bronchial asthma, right? It can precipitate bronchial asthma. Pilocarpine is a M3 agonist. It's a myotic agent. Betaxolol is a selective beta blocker. Selective beta blocker. It is considered as a preferred beta blocker. Preferred beta blocker in bronchial asthma patient with open angle glaucoma. So if there is a bronchial asthma patient with the open angle glaucoma, timolol should not be used. Then examiner asks, okay, if it is not used, what are you going to use then? Then you can use betaxolol. The cardioselective beta blocker is the one that is having lesser effect on the lungs. Apraclonidine, brimonidine, these are the alpha 2 agonists. They are the alpha 2 agonists. Remember, they are a sympatholytic drug, and they will be decreasing the aqueous production. They are going to decrease the aqueous production, and they are also going to increase the uveoscleral outflow. They are not associated with any bronchoconstricting like ADR. They are having some ADR like lid retraction and all, but they do not have bronchoconstricting. Timolol is the correct answer for this question. I hope all of you guys have got this. Let's see the next one. A 29-year-old lady who is a smoker on nicotine replacement therapy. All right. So she's a smoker. She's on nicotine replacement therapy for smoking de-addiction. She now requires an alternative therapy. So usually whenever there is a smoking dependence, what we actually do, we always try to do NRT. NRT is nicotine replacement therapy. So we try to give nicotinic gum or nicotinic patch or nicotinic inhaler, right? Nicotinic gum patch or inhaler we will be giving. So right now your patient is already taking nicotine replacement therapy. Alternatively, if it's not responsive, alternatively what you can use, if it is non-responsive to this, then we are going to give drug like your varenicline. We can give drug like your varenicline, or you can even give bupropion. But out of this, if you have to choose one, varenicline is the more effective drug that is having partial agonistic action at the nicotine receptor. Bupropion, it is considered as a preferred agent. Bupropion is a drug that we have. It is preferred in depressed patients. So whenever there is history of depression with nicotine dependence or smoking dependence, so depression with smoking dependence, in that it is the drug of choice. It is the drug of choice for nicotine dependence if there is a history of depression. Bupropion, it is a receptor modulator, plus it is also having partial agonistic action at the nicotine. So you can say Piona, bupropion, Piona, you can easily remember. Varenicline, it is having nicotinic receptor pe partial agonist. So they try to keep the nicotinic receptor clean. You can just remember like this. Correct answer for this question is varenicline. Why not flumazenil? Please remember, flumazenil that we have, it is the antidote for flumazenil. It is the antidote for benzodiazepines like diazepam, benzodiazepine overdose के लिए antidote है. Acamprosate, it is going to decrease the alcohol craving. Naltrexone actually is an opioid receptor antagonist. It's an opioid receptor antagonist, and they are mainly utilized in treatment of opioid de-addiction. It is utilized in the treatment of opioid de-addiction therapy. In opioid de-addiction therapy, we are going to use naltrexone. Remember, to prevent the relapse. The aim is to prevent the relapse. So it has been asked previously as well, but another question examiner asked that what is the antidote of opioid overdose? So opioid overdose ka antidote. What is the antidote of opioid overdose? The answer to this question will be naloxone. I hope that there is no confusion here, that naloxone definitely is one agent that we can utilize as an opioid antidote, and this was also asked in one of the very recent examination. Plus naltrexone is also one of the opioid antagonists. It's orally available and it is utilized to prevent the relapse in the opioid de-addiction. After the methadone substitution therapy, we are going to use naltrexone. Acamprosate is a drug that is going to decrease the alcohol craving. It is having NMDA receptor blocking property. Flumazenil is the antidote for benzodiazepine poisoning or benzodiazepine overdose. So varenicline is as the correct answer. As I told you, they are having partial agonistic action at the nicotinic receptor. The specific site is alpha 3 beta 4 and alpha 4 beta 2, right? They are having these are the specific site that we have. Okay, rest of the detail about nicotine, varenicline has been given already here, that when they bind at the NN receptor, the following outcome will be noted. They inhibit competitively binding with the nicotine. You are going to give a drug varenicline, they will partially stimulate the nicotine receptor, and it is always said that when a full agonist and partial agonist are given, this partial agonist will be acting as an antagonist. I repeat, when a full agonist and partial agonist are given together, this partial agonist will have chances also to bind, and you are going to use varenicline ahead of time. So this varenicline will occupy the site of nicotine, and after this, when the patient consumes cigarette or any cigarette, I would say, when the patient or person consumes cigarette, he will not have that level of euphoria. So it competitively inhibit binding of nicotine, decrease symptoms of nicotine withdrawal as well. Of course, withdrawal symptom ko bhi kam karega, and it also blocks the dopaminergic stimulation responsible for the reinforcement of the pleasure. The reward associated or the pleasure associated with the smoking, that will also be reduced. So again, these are the important outcome after blocking the NN receptor. Next, again, another second question on bronchial asthma, same year, same exam. A patient suffering from bronchial asthma comes to in hospital. Which of the following all of the following drugs are used in the acute exacerbation except? Now this is very, very important. You have to see there is except. All of the following can be used in acute exacerbation except. Please remember, in acute exacerbation, what all agent that you can use? You can use beta 2 agonist, drugs like your salbutamol, which is available by IV, inhalational, oral, in every form, syrup form maybe it's available. Also, you can use drug like formoterol. Formoterol is a long-acting beta 2 agonist, and also it's a fast-acting. Definitely, you can add oxygen as well, steroid as well. In resistant or in status asthmaticus condition, non-responsive to beta 2 agonist, steroid and oxygen, you can even add IV magnesium sulfate. Please remember, IV magnesium sulfate, they are also having bronchodilating property. But given the scenario that we have, the examiner is giving an option leukotriene antagonist. Please remember, leukotriene antagonists, drugs like your montelukast, zafirlukast, zafirlukast, pranlukast, they can be utilized for treatment of allergy. They can be utilized for the prophylaxis. For the treatment of allergy, you can utilize. For the prophylaxis of bronchial asthma, you can utilize, but it is not utilized in the acute attack. Remember, they are slow acting drug, and again, they are not available in the inhalational form as well, neither in the IV form. So leukotriene receptor antagonists, they are the drug that is not used in the acute attack out of the given choices that we have. All right, D is the correct answer. A patient with bladder cancer on chemotherapy drug, who is also a known case of CKD, developed a tumor lysis syndrome. Somewhere or the other, I don't know, in NEET PG, INI, and FMGE, this topic of uric acid, gout, tumor lysis syndrome is being asked from last 3 years in every examination. Okay? So they have developed tumor lysis syndrome and having high level of uric acid, Which of the following drug can provide the fastest reduction of uric acid? Fastest reduction of uric acid. Remember, the name of the drug is rasburicase. There is some, these rasburicase, and there is one more known as your p-glotticase. Please remember, rasburicase and p-glotticase. What are these? These are the recombinant uricase. These are the recombinant uricase. That means they are recombinant drug derived from the urine and feces of the birds. This recombinant uricase, it causes uric acid ka breakdown to allantoin. This uric acid breakdown to allantoin. Allantoin will be a water soluble metabolite that can easily be excreted. Normally we do not have this, we don't have a uricase enzyme. It is derived from the birds, right? So birds urine, so we actually call it as a recombinant uricase. So uric acid ka metabolism will be increased to allantoin. So they are the fastest. They are the fastest to reduce. Now, can allopurinol also reduce? Allopurinol will definitely reduce, but again, if it is asking fastest reduction in the tumor lysis syndrome, that is going to be your rasburicase. Febuxostat, they are the xanthine oxidase inhibitor. Allopurinol, likewise, they are the xanthine oxidase inhibitor. Both of them are xanthine oxidase inhibitor. They are the drug of choice in chronic gout. Mannitol is an osmotic diuretic. Mannitol has no role right now. However, in dialysis disequilibrium syndrome, definitely we can use mannitol, right? Can be utilized in acute cerebral edema, in the treatment of increased intracranial pressure, increase in the intraocular pressure, and also can be utilized for the treatment of dialysis disequilibrium syndrome. Dialysis disequilibrium syndrome that I am discussing here has been asked previously also in one of the 2022 NEET PG examination. Okay, so correct answer for this question, it is going to be none other than your rasburicase, right, among the given choices. Moving forward, again the same information has been given. It's a recombinant uricase, and they are decreasing the uric acid more effectively than allopurinol. Okay, all right. A 28-year female with first trimester pregnancy comes to you in the hospital with a high level of T3 and T4. So, high level of T3, T4 means there is going to be hyperthyroidism, and if it would be saying high level of TSH, then we would be saying hypothyroidism. But here there is a hyperthyroidism, and examiner is asking which of the following drug is most appropriate. So, there is a case of pregnancy. In the hyperthyroidism, you will be giving antithyroid drug. For the treatment of hyperthyroidism, you are going to use antithyroid drug, and for the management in the first trimester of the pregnancy, you will be using propyl thiouracil, PTU, propyl thiouracil, which is a thyroid peroxidase inhibitor, TP inhibitor, thyroid peroxidase inhibitor. That is in the first trimester. Then we are having second and third trimester. In this one, you can use methimazole or carbimazole, or methimazole. Please do remember a very, very important thing, that this methimazole or carbimazole, if it is exposed in the first trimester, right, if it is exposed in the first trimester, these are associated with a teratogenic effect known as your aplasia cutis, right? They are associated with teratogenic effect known as your aplasia cutis, choanal atresia, choanal and esophageal atresia, hypothyroidism, right? These are the important problem that can be associated with this drug if exposed in the first trimester, right? If exposed in the first trimester, exposure in the first trimester. All right. So this will be about methimazole, carbimazole. In the second, third trimester, yes, we can utilize once the organogenesis is done. Okay. So carbimazole first trimester में नहीं use करेंगे. Propyl thiouracil is the preferred one. Potassium iodide again is not the one that is going to be preferred. Propranolol is a non-selective beta blocker, and non-selective beta blockers are not selected in pregnancy. It is never given in pregnancy. Next, 29-year-old female with a history of hypercoagulable disorder visiting the OPD for anticoagulation. Which of the following drugs should be avoided in the first trimester of the pregnancy? Again, there is another case of pregnancy. So, in the first trimester, what should be avoided? Again, warfarin in the first trimester, we should avoid warfarin. Unfractionated heparin, low molecular weight heparin, they are the preferred, but warfarin is avoided because warfarin is associated with a condition known as your fetal warfarin syndrome. FWS is fetal warfarin syndrome, also given the name as a Contradi syndrome. Contradi syndrome. In the fetal warfarin syndrome or Contradi syndrome, usually there will be skeletal and facial defect. Skeletal and facial defect. There can also be nasal septal defect. Na? Skeletal cartilaginous defects are also there. Na? Cartilaginous defect can also be seen. Because of the cartilaginous defect, there can be flat nose as well. Na? Cartilaginous defect can also be seen. So, warfarin in the first trimester is not used. So, always remember, if you are going to use anticoagulation during pregnancy, na? If you are going to use anticoagulation in pregnancy, then usually in the first trimester, from 1 to 13th week, we try to use low molecular weight heparin or unfractionated heparin. From 1 to beginning of the 13th week, that means end of the 12th week, beginning of 13th week. From 13 to 35th week, we can use warfarin because again we will be needing stronger anticoagulant. Warfarin is much stronger anticoagulant compared to heparin. Then in the 36th week, we are going to switch again to low molecular weight heparin or unfractionated heparin, either of them. I hope it is making sense to all of you guys. All right, next. Which of the following drug is used as a agent of choice or drug of choice in Legionnaires disease? Very commonly asked question. And remember, in Legionnaires disease, in fact, any other atypical infection, Legionnaires disease, Legionella, atypical, infection of the lungs that is caused by, let's say, mycoplasma, chlamydia, or atypical infection like Legionnaires disease caused by Legionella. For all of them, the drug of choice, it is going to be azithromycin. Macrolide, azithromycin is the drug of choice. Okay? Not the erythromycin. Erythromycin has again pharmacokinetic property like shorter T half-life, lots of drug interaction because of its enzyme inhibiting property. Vancomycin that we have, it's not preferred in Legionnaires disease. It's mainly considered the drug of choice in a patient with the MRSA, methicillin resistant staph aureus. It is the drug of choice also for staph, catheter associated staph epidermidis infection, catheter associated staph epidermidis. Okay. It is also a highly preferred drug in pseudomembranous colitis. Earlier it was the drug of choice as well. In the oral dose mein vancomycin we were using, but again they are the among first line only. Currently the drug of choice for pseudomembranous colitis is fidaxomicin, one of the macrolide. Okay. Tigecycline, it is one of the congener of minocycline only. It's from the tetracycline family. Minocycline is from the tetracycline. One of the congener of the minocycline is tigecycline, that is having much better pharmacokinetic property, and it is also safe in renal failure. Which one? Tigecycline. And it can also be utilized in VRSA. If it can be utilized in VRSA, can also be utilized in the MRSA as well. VRSA, MRSA, for all of them you can use them. All right. So azithromycin is the correct answer for this question. A patient suffering from breast cancer is on chemotherapy, taking multiple anti-cancer drugs. As the cancer is not responding to the low dose of therapy, there needs to be increase in the dose of the chemotherapy. Which of the following agent require monitoring of the bladder function? Now, very typical question, and as I have told you many times in the classes, that your examination has become, your pharma has become clinical pharmacology, and now even the simplest of the question can be given in a form of case. So most of the question, if you see, they are going to talk about a disease or a case scenario. Wherever they are asking about a disease. Here, if they wanted, they would have just asked which of the following drug causes toxicity to the bladder, or any other drug that is causing, let's say, hemorrhagic cystitis. But here they are giving you a case. A patient is being treated on blah blah blah, and now he is having non-responsive cancer. You are going to increase the dose. Which drug will be requiring monitoring bladder function? So as simple as that. The basic concept remains the same. It's just that the pattern of asking has been changed. The correct answer is going to be ifosfamide. Please do remember drugs like your cyclophosphamide, and ifosfamide. Out of them, ifosfamide is more, notorious as compared to cyclophosphamide. These agents, ifosfamide and cyclophosphamide, these are actually metabolized, and one of the metabolite is known as your acrolein. Acrolein is one of the metabolite of cyclophosphamide and ifosfamide. This acrolein actually is toxic to the bladder, and because it is toxic to the bladder, it can lead to problem like your hemorrhagic cystitis, hematuria. Hemorrhagic cystitis, hematuria can also lead to bladder fibrosis. Can also lead to bladder fibrosis. So with the drug like cyclophosphamide, ifosfamide, you always will be needing monitoring of the bladder function. And if you want to avoid this kind of toxicity like hemorrhagic cystitis, hematuria, bladder fibrosis, so as a prophylactic step, you will be adding IV mesna. You try to run an infusion of IV mesna prior to starting this cyclo or the ifosfamide. Okay. There is one more metabolite of this drug, just an add-on information because they have already asked about this one a couple of times. There is one more metabolite, and this metabolite of cyclophosphamide, it is given the name as a chloroacetaldehyde. It is given the name as a chloroacetaldehyde. It's another toxic metabolite, and this chloroacetaldehyde, it is associated with a side effect known as your peripheral neuropathy. It can cause peripheral neuropathy. All right. So monitoring of bladder function again with the ifosfamide. Then we are having, let's say, methotrexate. They will be mainly associated with bone marrow suppression. They will be associated with your megaloblastic anemia. To reduce the toxicity of methotrexate, we always try to add a folinic acid, also given the name as a leucovorin. Then we have one more, cisplatin. It is highly nephrotoxic drug. To reduce the toxicity of nephrotoxic effect of cisplatin, we are going to add amifostine. Apart from that, remember, cisplatin is also one of the drugs that is having ototoxic property, and it is the most hematogenic anti-cancer drug. It is the most hematogenic, so maximum risk of nausea and vomiting. NNV, nausea and vomiting, most hematogenic anti-cancer drug. Gemcitabine will have the usual side effect, and in addition to that, remember, gemcitabine, it is also associated with hemolytic uremic syndrome, in addition to the other side effect like bone marrow suppression, alopecia, aphthous ulcer, right? In addition to that, they will have an additional, that is hemolytic uremic syndrome. Another question about gemcitabine that is very, very expected, that gemcitabine is considered as a drug of choice in pancreatic cancer. Drug of choice in pancreatic cancer, it is none other than your gemcitabine. Correct answer for this question is none other than ifosfamide. Moving forward to the next one. A young male patient who has a family history of bipolar disorder in his father, he now comes to OPD with the symptoms of mania. His genetic test shows positivity for recessive inheritance of genes involved in the mania. Which of the following mood stabilizer can be used? So simply they would have asked which of the following drug that is preferred in mania or used in mania. The answer is none other than lithium. Lithium is the drug of choice for mania. It is also utilized for the drug of choice for prophylaxis of mania. The answer for both the scenario, it is going to be lithium. But if the examiner is going to tell you that lithium alone is effective in acute attack of mania, please remember, for the acute mania, we can give lithium, but we need to add a sedatives. So sedatives currently that is preferred is your atypical antipsychotics, or benzodiazepines. Atypical antipsychotics or benzodiazepine, and in addition to that, you will be adding lithium. Please do remember that complete onset of action of lithium will take around 2 to 3 weeks. And in acute attack, you cannot just give lithium and you can rely that okay, the acute attack will be controlled. No, it will take around 2 to 3 weeks. Once the symptom is controlled with the atypical antipsychotics or the benzodiazepine, then slowly after 2 weeks you can withdraw those drugs and you can continue only on the lithium. Okay, so this is simply a case of mania or bipolar disorder, manic phase of bipolar disorder. The answer to this question is lithium. So preferred is lithium. But can we also have valproate? Can we also give valproate? Yes. In the manic phase of bipolar disorder, we can use valproate. In fact, valproate is the drug of choice for rapid cycler in a bipolar disorder. Rapid cycler, anyone who is having more than or equal to 4 cycle per year, उसको बोलते हैं रैपिड साइक्लर. So bipolar disorder में again it's a drug of choice. ठीक है. But again in the manic phase of bipolar disorder or simply in the mania, the drug of choice is going to be none other than your lithium. All right. Carbamazepine can also be used in bipolar disorder in the manic phase of bipolar disorder. And olanzapine is a typical antipsychotics. A patient of myocardial infarction taking antiplatelet drug, aspirin, like 325 milligram aspirin. So aspirin is an antiplatelet drug, and this antiplatelet effect mainly is achieved due to the cyclooxygenase 1 inhibition. Okay. Which other drug can be added to the above therapy? Okay, so they are asking which drug will be added with aspirin. So with the aspirin, we always add aspirin is one of the COX-1 inhibitor, and in addition to that, we also add P2Y12 inhibitor. This P2Y12 inhibitor are drugs like your clopidogrel, prasugrel, है ना? Clopidogrel, prasugrel, and together we call them dual antiplatelet therapy, DAPT, dual antiplatelet therapy. In a patient with acute coronary syndrome, in a patient with myocardial infarction, this dual antiplatelet therapy studies have shown it is having 20% better outcome as compared to antiplatelet drug aspirin alone. So when we say dual antiplatelet therapy, we are going to talk about that drugs like COX-1 inhibitor like aspirin and P2Y12 inhibitor like clopidogrel. So usko bolte hain dual antiplatelet therapy. So here what will be added? Clopidogrel. Dipyridamole is an antiplatelet drug. It's a phosphodiesterase 3 inhibitor. Heparin is one of the anticoagulant. Warfarin is also one of the anticoagulant. Heparin is injectable, warfarin is oral. But here they are asking about antiplatelet activity. So warfarin, heparin are not antiplatelet, they are anticoagulant. Okay. Mechanism of action of aspirin in patients suffering from thrombosis. So see, this question itself I told you, COX-1 inhibitor is going to be aspirin. So mechanism of action of aspirin. So here the answer to this question is going to be inhibition of cyclooxygenase 1. P2Y12 inhibitor, I told you drugs like your clopidogrel, prasugrel, clopidogrel, prasugrel, ticlopidine. So in fact, examiner oftentimes simply asks also what is the mechanism of action of prasugrel or clopidogrel. Okay, so these are the irreversible P2Y12 inhibitor. Irreversible P2Y12 inhibitor. There is something called reversible P2Y12 inhibitor as well, and these are your cangrelor and ticagrelor. Cangrelor and ticagrelor. These are the reversible P2Y12 inhibitor. Okay. Fibrinolytics by converting plasminogen to plasmin. See, these are known as your tissue plasminogen activator. Tissue plasminogen activator drugs like your streptokinase, urokinase, streptokinase, urokinase, LTplase, anistriptase, tenecteplase. These are the fibrinolytics. इनको बोलते हैं fibrinolytic. They cause conversion of plasminogen to plasmin, and this plasmin will be causing fibrinolysis. Inhibiting conversion of vitamin K1 dependent. The vitamin K dependent, this will be mainly your warfarin, not your aspirin. Okay. So I think other options have been also clarified here that COX-1 will be producing your antiplatelet activity. P2Y12 inhibitors are drugs like clopidogrel, prasugrel, and fibrinolytics are streptokinase and इनको बोलते हैं tissue plasminogen activator, है ना, streptokinase, urokinase, and anistriptase, LTplase, tenecteplase, all those. Okay. Which of the following best drug for Raynaud's? For Raynaud's, the best drug, the most preferred drug that we are having is none other than your calcium channel blocker. Specifically, drugs like your amlodipine, nifedipine, We have other drugs as well. Like you can use topical nitrates. Nitrate topical, not nitroprusside. Nitroprusside is systemic drug. Beta blocker is not utilized. However, you can use alpha blocker as well. But if you compare calcium channel blocker and alpha blocker like prazosin, alpha blocker is having less effectivity as compared to calcium channel blocker. So calcium channel blocker are more preferred in Raynaud's phenomena. है ना? So we have drugs like nifedipine, amlodipine, and also they are taking diltiazem. है ना? They appear to provide symptomatic relief in Raynaud's. Some studies indicated that prazosin can decrease the incidence of digital vasospasm in patients with Raynaud's. However, its relative efficacy as compared to calcium channel blocker is not known. So this is a direct reference of this one is Goodman-Gilman 14th edition. All right. So the preferred one is going to be your calcium channel blocker. Which of the following is the most important and significant side effect of tamoxifen? See, tamoxifen, it is one of the selective estrogen receptor modulator. Is an estrogen receptor modulator. That means at some area they are agonist, at some area they are antagonist. So usually they are a drug of choice for ER positive and PR positive breast cancer. Drugs like your tamoxifen, raloxifene, right? So they are going to antagonize this, right? But they are also having agonistic action. They are having agonistic action at areas like your endometrium. They are having endometrium. Because of that, they can lead to endometrial hyperplasia. Endometrial hyperplasia and can increase the risk of endometrial cancer. They can lead to endometrial cancer. But they are also having agonistic action at other area like bone. Because they are having agonistic action at bone, they are going to increase the blastic activity and they are going to utilize the treatment of osteoporosis. Right? So they are having agonistic action in many area, antagonistic action in some areas, right? So again, endometrium antagonistic action can be leading to hyperplasia. So which of the following is the most important? So because of this reason only, we are not preferring this tamoxifen in in a postmenopausal women because of the increasing risk of hyperplasia. So alternative to this one, alternative to tamoxifen that we have is known as your raloxifene. Raloxifene, it do not cause endometrial hyperplasia because it is not having agonistic action. In fact, it is having antagonistic activity. It do not cause endometrial hyperplasia. So that is one of the second generation selective estrogen receptor modulator. So raloxifene is a relief actually. All right. So this is the same detail taken from the textbook. Whatever information is there, I have told you already, same detail. So tamoxifen is a SERM, I have told you already, widely used in ERPR positive breast cancer, agonistic action over bone, therefore used in osteoporosis. They also have agonistic action at liver, uterine, endometrium. So the important point is agonistic action at uterine endometrium that is causing endometrial hyperplasia. Okay. It's utilized also in the treatment of osteoporosis because of its agonistic action at the bone. Because of its agonistic action in the liver, it can increase the lipid metabolism. Hence, they can also decrease the LDL level. So, somewhere it is good as well. They are going to decrease the LDL level. So, this is about your tamoxifen. Tamoxifen always, one point, tamoxifen can increase the risk of endometrial carcinoma. Next, a patient who has just recovered from COVID-19. So COVID-19 we have just seen. COVID wave ke baad se we had very massive surge of mucormycosis, and they always present with the black discoloration in the nose and posterior part of buccal cavity. He also gives the history of using high dose of steroid. So all of them they will be pointing towards mucormycosis. Post COVID, black fungus के नाम से they were famous, mucormycosis, and the drug of choice for that condition is going to be your amphotericin B, an antifungal drug that is going to act at the fungal cell membrane. So amphotericin B, it is considered as a drug of choice in this scenario, not any other drug. In fact, drugs like fluconazole, itraconazole, they are not very effective in mucor, and later on posaconazole was used. But if the examiner is asking most suitable or the most preferred, then amphotericin B is the drug of choice. For this one, we have quickly revised this once again. Thank you very much to all of you. I'll see you in the next class.